Listen now to a discussion Peter McCullough had with Dr. Daniel Lenihan, professor of medicine at Vanderbilt University in Nashville, Tennessee, on cardiac safety during chemotherapy, the scope of the problem.
Dan, welcome to ACCEL.
Thank you very much.
So, Dan, I'm going to ask you just briefly to touch upon, I think, what's the most familiar topic to cardiologists, and that is anthracycline myocardial toxicity.
Yes, well, I think that when you think of cardiac toxicity, most people would be concerned about left ventricular dysfunction that may occur, and so anthracyclines are a perfect example of that. But if you think about sort of the broader definition of cardiac toxicity, which could be hypertension or some other complication, that's when we have to start thinking about other drugs that may have an important impact on the cardiovascular system.
So with anthracyclines, so doxorubicin, it's well known that there's this cumulative dose-related toxicity and reductions in ejection fraction. Are there any new understandings or advances in this area?
Yes, well, it's amazing that that drug has been used for 30 or 40 years in a variety of contexts, and from an oncology point of view, it doesn't seem like it's going away. They're going to continue to use it for, very important cancers, so it's a very common drug. But, we believe that there is permanent myocardial dysfunction from a certain threshold amount of anthracyclines that is given. But I believe that there's unequivocal evidence that that's not exactly true, that probably there's ongoing damage whenever patients are treated with anthracyclines, and ways that we can help to manage that going forward is a really important part of what cardiology can do.
So in your view, should we have measurements like ejection fraction and blood B-type natriuretic peptide on the chart before patients receive these drugs?
Absolutely. The simple recommendation is to make sure that there's an assessment of LV function, but I would also say that you would want to have a broad view of their cardiovascular risks going into any treatment with chemotherapy. And part of that is because these patients are older commonly, and they have comorbid conditions, and whatever way we can manage those better during a stressful time is going to be truly beneficial for the patient. So an EF measurement is certainly an appropriate step. I would include other blood tests, including a lipid profile, a BNP, plus maybe a troponin, as assessments of where the patient sits, right now, and going forward, you have a measurement to compare to.
Now, how about 5-fluorouracil?
That's a common drug for a variety of cancers. It has been used in many, many patients. So the biggest issue that we tend to counter in that is that it may exacerbate ischemia, possibly due from a vasospasm type mechanism. So that occurs. It's not one of the more common things, but it does occur, and it is something to keep in mind.
And then how about platinum-based therapies?
Platinum-based therapies are used, possibly the most common overall drug. I'm not sure about that, but anyway, a very commonly used drug. And I think the biggest issues that we see with platinum-based therapies are longstanding hypertension, and then, at least from a scientific model, it looks as though there is a significant reduction in their small vessels that lead to potentially the peripheral neuropathy, which is a clinical problem that occurs commonly in cisplatin. So the belief that it's a nerve toxicity may be actually a vascular toxicity that's leading to a nerve problem. So I think that considering how we can best manage a vascular condition with patients that are getting cisplatin is an important concept.
And with oncology, there's been an absolute explosion in terms of biologics and monoclonal antibodies that they themselves that target various receptors. They can be loaded with chemotherapy on the monoclonal antibody or with radioactive substances. And so we know that anti-HER2 therapy now has a cardiotoxicity. Can you tell the audience more?
Yes, that's actually, in the last 10 or 15 years in the oncology world, their whole focus and strength of their treatments have been based on, various targeted mechanisms. And in the case of breast cancer, a HER2 receptor overexpression is a more aggressive form of breast cancer, and when they developed a target to reduce the growth of that cancer, it was a huge benefit from a cancer point of view, but as it turns out, there was a higher than expected signal for toxicity, for cardiac toxicity. And over time, it became apparent that there is a HER2 receptor on the myocardium. And there are actually a host of receptors on the myocardium that we didn't even know about prior to this clinical development. And so from a cardiology or heart failure point of view, the HER2-based therapies are something that we always have to consider when patients develop heart failure, or they're certainly at risk for heart failure whenever they're getting that type of medication.
And can you mention the names of some of these agents?
The most famous and most popular is trastuzumab, or Herceptin, the trade name for it. It's a massively important drug in that oncology population, and they're trying to expand the indications beyond just the classic breast cancer population to other cancers that may benefit from it. But that's one of the biggest cancer drugs out there.
Anti-growth factor area, anti-VEGF area in chemotherapy. In cardiology, we actually were giving vascular endothelial-derived growth factors as a form of therapy. And in cancer, in order to reduce the blood supply of tumors, we actually give therapy that works in the opposite direction. So tell us about that.
People who came to various international cardiology meetings a decade ago would have heard a lot of discussion about VEGF-based therapy as a treatment for ischemia in some fashion. So from cardiology, we tried it. We didn't get too far. And at that same time in oncology, they were really focused on trying to reduce angiogenic growth factors to tumors with the hope of improving cancer control. And they've actually found some significant successes by doing that. But of course, if your blood vessels normally would, we think that they would like VEGF, and you give a drug in which VEGF or some other growth factor is inhibited, then it wouldn't be difficult to imagine that you might have a cardiovascular impact with that. And clinically, we find that some patients can develop very significant hypertension in a very short period of time. And certainly that has to be made aware to a patient and their provider just for safety purposes. And then also there are angiogenic growth factors that are present on the myocardial cell or as part of the machinery, and inhibiting those, it's not unheard of that we would have, direct myocardial toxicity also.
So would patients actually develop ischemic heart disease as a result of these drugs?
Yes and no. I think that we've caught a few signals of that in the oncology world, but I'm not sure that it is, it's not a uniform presentation, and I wouldn't say it's extremely common, but yes, we have seen evidence of worsening ischemia and or even fatal cardiac events in anti-VEGF-based therapy.
And what are some of the names of agents in this class?
There may be 6 or 7 that are FDA approved right now, but the most common, or the first one, was Avastin. There's Sutent and Sorafenib. Those are 2 other drugs. There's Vandetanib. There are a variety.
If you take an average patient that we have in the cardiology office with background coronary disease and maybe mildly impaired LV function, and they develop some common solid tumor, neoplasm, breast cancer, colon cancer, lung cancer, and they're approaching chemotherapy, are there any cardiovascularly safe chemotherapeutic regimens, or in every instance, should we be vigilant with this background assessment of LV function, natriuretic peptides, following these through, and then our standard cardiovascular treatments for myocardial disease and coronary disease?
It's really incumbent on us as cardiology to chime in on our patients and do their best to prevent any development of significant cardiac problems. If they already have them, then having some exacerbation is quite likely almost with any of these chemotherapy regimens. Certainly there are some that are more famous for affecting cardiovascular system than others, but all of them are stressful. And if we can do a better job of managing their cardiac risk factors or their underlying cardiac disease, then there's no question that a cardiologist can make a big impact on how that patient does.
Well, Dan, I'll let that be the last word, and thank you for joining us on ACCEL.
Thank you so much.